go, and I will turn it over to Colin.
All right, great. Appreciate it. Thanks for having me, and thanks for organizing this. This is something that I have done before with the Monroeville Public Library, and it always seemed to be something that we get some good outcomes from. And the big idea here is that, like, Alliance Physical Therapy is a small private practice, and we want to be, one of our big goals is building relationships both with our patients to help them get better and improve towards improving their daily function, but then also build relationships within our community. So this is part of that endeavor, trying to just kind of connect to the Murraysville community. Because we do have a practice here in Murraysville, which is where I practice, and then we also have a practice in Penn Hills. So what I've done in the past with this is kind of created a series out of this, like multiple lectures that focus on things that people often bring up to me in the clinic that are common issues that people confront, and low back pain is a very common issue that people confront. So my goal is to help just give everyone a little bit of education on this, so that they're not going in to their doctor's appointments or PT appointments with absolutely no knowledge. They can have an idea of what to expect and what to hope for. And even these days with medical specialization, the way that it often is and it often goes, is that you can easily get passed around from practitioner to practitioner, and you really have to be your own primary care practitioner a lot of times. So giving you a little bit of baseline knowledge on what the expectations are with low back issues, what the research is generally saying, will give you an opportunity to make hopefully a well-informed decision, and then hopefully tell your friends that they may be suffering from some back pain as well, what you learned, and pass that knowledge on. So that's the main goal. Hopefully that's what you take out of it. There's more lectures that we can bring into this. We're planning on doing one on osteoarthritis and osteoporosis, but I also have some lectures that I discuss just general exercise principles, which I will talk about a little bit at the end of this discussion, but I really get excited about those because that's pretty much what physical therapy is. We're stressing the body to help it rebuild, and we can talk a little bit more about that. But the idea here is just to pass on some knowledge to help people have a better handle on their musculoskeletal system, like their bones and joints and muscles, as they continue to grow. Okay, so I'm going to share my email there in the chat. So if you have any questions afterwards, please feel free to reach out, and no questions or silly questions, just reach out and let me know what you have. And then I'm going to share my screen with this. Okay. So hopefully everybody can see that. Somebody speak up if they can't. But this is just to keep myself focused and give you guys some information, just some little facts and information as we go through this. But generally, we're going to be talking about low back pain here. So this is the lowdown on low back pain. And I'm sure if you're listening to this and you've tuned into this, then it's no secret to you that low back pain is a pretty common issue that is suffered by many Americans. In fact, 98% chance that we will experience significant low back pain in our lifetime. So it's pretty much going to happen. Now, that doesn't mean it's going to become chronic and persistent low back pain. That doesn't even mean it's back pain that you really have to do any significant amount of treatment or therapy for, but that's the population in general is going to experience low back pain. Lower back pain is the second most common reason for visiting our primary care practitioners. So next to the cold, it's low back pain. So this is something that is pandemic across the world, really. That term is thrown out quite a bit recently, but it really is. I mean, there is a low back pain epidemic across the United States, just like there's an obesity epidemic. So these things actually go hand in hand quite a bit, but these are things that we want to, services like this and just doing some public health education is the way to help people overcome these issues. And with low back pain, so much of it is knowledge and understanding what it means to have low back pain and what the best practices are to help manage it. Because realistically, 25% of cases become chronic. So if you take that and go back up to that 98% of people that get it, so that means that they're quarter of our population almost has chronic back pain. That's an issue. I mean, that's a big issue. And that's something that if we just got the information out there of how best to manage it, people would be able to would be able to pursue the right care, and we wouldn't necessarily in all cases be able to get rid of the low back pain, but the hope is to give you some principles on how to best manage it. And that's our hope with this presentation. So as I go through, feel free to ask questions. I'll try to keep the chat box open because most people don't like to talk on this. I don't like to talk either. So feel free to throw some chats in there. I'll try to answer those as I come to them. But if you do, just want to unmute yourselves and talk too, that's fine. This is really for you guys. So if I'm talking about stuff you don't care about, then redirect me. But the idea here is to just give some general knowledge on low back and pain and what people experience when they go through the medical model as of now, and what it could look like if you are as things change throughout the next number of years with our knowledge base as it grows. So the biggest thing that people come to me with once they have been diagnosed with lower back pain is the terminology. So they come to me with all these words that sound terrifying. Like one of my favorites is Spondylolisthesis. And that word is just really long and scary sounding. So right there. And yes, that is something that we wouldn't want in our back, but it's something that is very manageable, and it doesn't mean that it's something that we need to have surgery for. So that's kind of where I went up here and said bigger bark than bite with a lot of this terminology. It sounds scary, but it doesn't mean that your back is falling apart. So spondylolisthesis, for example, is when the back is made up of vertebral bodies, like bones that sit on top of each other, and there's a little disc in between. And it's when those bones shift back and forth on each other, and it's identified through X-ray, and we can see that there's a little bit of shifting in those bones. Typically, it means that there's the spinal ligamentous structures that hold the bones to bones aren't as stable as we'd like them to be. So there's a little extra movement. But people live just fine with spondylolisthesis and don't have any issues. Then we have, so I'm not necessarily, I'm going to just kind of skim over these because this is something that is pretty common that people will come and ask questions about, and then we'll get into what this means for our management. So then if we go back to the beginning of stenosis, it means a narrowing in some sort of hole. So in the spine, we have two areas where it can narrow, either along where the spinal cord travels through all the vertebral bodies, or where the nerves come out of the spine and go out to your limbs and arms and everything. So we can have central stenosis or foraminal stenosis is what that means. Foramen are the little holes that the nerve roots go out of. And this is something that happens commonly as we age. There's some calcification and narrowing begins. So this is something that if you're an older individual, you probably have seen this on like an image, an X-ray or an MRI that has been taken of your spine. And honestly, if you're really over the age of like 30, we could maybe say 40, it would be abnormal to not have these changes in your spine. So that's something to remember. These are normal age-related changes often that are happening. Now, that's not to say that they couldn't be painful changes. They couldn't cause pain because they certainly can, but it doesn't mean that they always have to have change. So much like arthritis in the knee, it's something that can be there without pain, and so it's not really a problem until it's painful. And speaking of arthritis, Facet Arthropathy is arthritis in the joints of the spine. So in our spine, we have what are called facet joints. They're not the discs, they're little joints behind where they glide and the vertebral bodies glide and slide on each other as we move. And we can develop some arthritis in those. And then we have spondylosis, which basically just means all these things. It's just age-related changes in the spine. It's a very general term, but it's thrown out there oftentimes, and it also sounds a little scary. So I wanted to kind of bring that up to everyone. So those are issues specific to some of the joints. Then we can move down to issues with the discs, which is another popular area in the spine to identify pathology. Disc bulges are very common. Basically, the disc is made up of if you think of your spinal discs as little jelly donuts, okay? You have the donut on the outside and the jelly on the inside. And sometimes if we move or twist or put abnormal stresses through the disc, the jelly on the inside pushes its way out to the edges. So if we have some disc bulging, it started to push out there, but it hasn't like broken through at all. A true disc herniation here is when that has actually pushed through, and we can actually see the jelly on the inside that's worked its way out. And then degenerative disc disease is basically when that jelly donut slowly over time turns into a regular donut and it basically all becomes very fibrous. So in a disc that has some degenerative disc disease in it, there's not a lot of fluid in it. So over time, it doesn't bounce back as much. So if you think about if you've ever noticed or been measured in the morning, like your height in the morning versus your height at night, you're always taller in the morning because over the course of the night, you're laying down and your spinal discs fill with fluid. Then you stand up and you walk around throughout your day, and those spinal discs slowly compress through the day. So a degenerated disc is one that is just kind of permanently compressed. You're not going to get a lot of bounce back from that disc. So there's just not as much as cushion in it. And it's, again, a very natural part of the aging process. In fact, that is something that if by the time you're late 20s, if you don't have some of that, it's pretty surprising. So these are things that are normal age-related changes as well. Disc herniation, not so much. That's not a normal age-related change. But disc bulges and degenerative disc disease are, and we can actually see that in this really confusing graph that we have. So I'll try to explain it as best as I can to make sense of it. But if you could see here, this is the MRI and CT findings of people without low back pain. So that's the most important thing to remember. These people don't have any complaints of low back pain. So these are normal controls. Over on the left, the y-axis, we have percent of asymptomatic population. So this is basically how many of these, the percent of this population that has one of these issues identified on their MRI or CT findings. And then here's your age on the x-axis. So we go, it just kind of, you can see it goes up to 90 there. So I talked about disc degeneration right here. So that's the blue line with a little line through it. You can follow my cursor. That's the top line here. You can see by the time you are, let's just pick an arbitrary number, 50, there's an 80% chance you have this. By the time you're 85, there's a 95% chance that this is identified. So this is super, super common. Disc signal loss is similar to the disc degeneration. Let's move down to disc bulge, the purple one, purple with the diamond. You can see that increases consistently over time. So by the time you're 70, it's almost an 80% chance of identifying that. Even the one that I said that sounded so scary, the Spondylolisthesis, which is just the regular purple line, by the time you are 40 and you don't have any low back pain, by the time you're 75 and you don't have any low back pain, there's a 40% chance that you have some spondylolisthesis. So all this to say that, yes, there are normal changes that occur, but I'm not discounting these changes. These changes can be significant if you have symptoms, but if you don't have symptoms, it's just a back that's getting a little older every day, which we all have. So this helps me understand these concepts. Hopefully it helped you understand it, and hopefully there weren't too many lines to confuse you. But that was a valuable resource that I often use in the clinic just to help people kind of see the big picture of all this. Because oftentimes people will come to me and say, listen, I don't know why I'm here. Well, I get often. I don't know why I'm here because I've got spondylolisthesis and a disc bulge and a herniated disc that you're not going to do anything about. And I say, you're absolutely right. I'm not going to do anything about that. Those things are there. The disc herniation could heal over time. but everything else is just going to be there. But we can work with them. We can help you move better with them, and that's the idea. We're not going to get rid of arthritis. We're not going to get rid of the degenerative disc diseases that have occurred. It's just something that's there. In fact, the term degenerative disc disease doesn't even sound right to me. I mean, to call something a disease that happens to everyone doesn't seem to make much sense. So it's just degenerative discs. But those are things that we'll work with and understand and take into consideration when we're creating your plan of care. But we will help you move better in spite of these things, and that's the idea. Then the last thing to talk about would be spinal fractures, which those are issues very specific to the bone. Spinal fractures are things that can occur both with traumatic events, like you fall and then you fracture your spine. A fractured spine doesn't mean you're paralyzed automatically. It just depends on how it fractures. The spine is the spinal cord is pretty well housed inside a lot of muscle and some fat tissue, and then your bones are protecting it. It's reasonably well protected, so the risk of that is low, thankfully. And then you have some other fractures that will occur, especially as we get older, which would be like compression fractures of the vertebral bodies, which those vertebral bodies are the bones that basically keep us upright, and they're the bones that are between our discs. And they have let's see, fine. Let's just pull this up so we can make sure I'm getting this across to everyone. Okay, that's not really where I want it to be. So you can see you have your discs, the blue.
It's gray.
Oh no. Okay.
Can you try resharing?
Yeah.
Thank you.
Oh, it looks like I can only share specific things. So, okay. So now I'm sharing again. Okay. So this is just a Google image. But you can see here we have your disc space right there, the blue, and then the white is the vertebral body. And back here would be like your spinous processes. These are the parts of the spine that you can touch whenever you push through your skin. So these vertebral bodies over time can compress and get compressed and actually fracture. When that occurs, that can be painful. And there's a lot of different concepts around management of those. The general idea, are we back? Can everyone see the original? Okay. The general idea, depending on your age, would determine what we do with that. And this is something we'll get deeper into when we do the talk about osteoporosis, because this is a common thing to occur during osteoporosis, that you'll get these fractures. And there's some ideas that with respect to the management that we can get deeper into. But so those are some of the common things that people come and talk to me about when they're concerned about their back. So when we have pain, when we have an injury or any issue, it's either acute or chronic. Like acute basically means it's just recently occurred. It's not been around for very long. Typically, somewhere like a chronic pain is one that's lingered around for at least 6 months. So acute is with like a day to a few weeks to a couple months. You could even, sometimes people will divide that acute down into acute and subacute. Subacute meaning it's been around for a little longer than acute, but the definition is kind of variable from what I've seen. So in the cases of acute low back pain, the biggest thing to remember is that early management prevents chronicity. So if you go up here, we can see that 25% of cases become chronic, but if we get in early, we can hope to prevent that and stop that chronicity. So everybody right away, and I've been there, like when you have pain in your back, it is terrible. And it is really painful, and it prevents you from doing a lot throughout your day. And you think like, I don't know how this is ever going to get better because this hurts so much, and every movement that I make hurts. And I get it, and that I've been there, and I've thought that, man, there's no way that there's not something serious wrong. I need to get something like a picture taken of my back. Someone needs to tell me what's going on here. But the reality is there's not really that many good reasons to have your back imaged, especially with acute pain. So a traumatic mechanism of injury is a good reason to get your back imaged. Something where you've had a blunt force to your back, you've fallen from a significant height, those are good reasons to have your back imaged. Progressive neurological symptoms, basically what that means is when we're talking about our low back, that means numbness and tingling getting progressively worse down the legs, weakness that's getting worse, something where you've actually lost control of your bowel and bladder function. Those things are good reasons to get your back imaged. Now, I'm not saying just numbness. Like if you just have some numbness from your spine, that's not a rush to get some imaging done. It's when that numbness is getting progressively worse over time, and kind of quickly over the course of a few days and maybe even just a week. And then another reason would be if you have had conservative care and you haven't had any response at all. It's not that your symptoms, we would expect your symptoms to be 100% better in 2 to 3 weeks, but no response at all from the treatment would be a good reason to get some imaging done. So those are some good things to keep in mind. I know when you have the pain, it might be hard to remember those, but that is something to keep in mind because that's the reality of what we know about low back pain, and oftentimes it's over-imaged, and it's imaged in situations that don't really need the imaging. Even in my own management and physical therapy, oftentimes people love to bring in the imaging for me, which is great, and it adds to my understanding of the whole picture. But you'll see as we talk later, the symptoms, what you experience in front of me in the clinic and what you tell me you experience throughout your day are more important to me than the imaging. The imaging makes sure that it's safe for me to intervene in certain cases, but I don't need it in all cases, and it is something that I'm more focused on, like how you're experiencing your pain. If symptoms are so severe that you can't really function throughout the day, then that's when you would consider some pharmaceutical management. Basically, what that means is if you're allowed to, you could take some NSAIDs. Obviously, you have to check with your primary care practitioner here, but you could take NSAIDs, which are non-steroidal anti-inflammatory, which basically means Advil and ibuprofen, and like Motrin, and Aleve is another one, which is naproxen. So those would be a good option. You could take regular pain medication like Tylenol, which is acetaminophen. You could consider talking to your doctor and getting like a dose pack, like a steroid dose pack that would help quickly bring down the inflammation and irritation. You could also consider talking to your doctor about getting some muscle relaxers or gabapentin, which is for nerve pain. So there's a lot of options there. And those would be good if the pain is really, really severe. If it's moderate, and you can live with it and move reasonably well, then you would, this is where you would want to kind of discuss more with your doctor. But all of these management, all the pharmacological management for low back pain is symptom control. So if symptoms are bad, you use it. If symptoms aren't terribly bad and you can live with them, then the reason to use it is not really there, I guess I could say. You've got to just try to work on staying moving, really. Now, in the first 7 to 10 days, it is good to give the body just some time to heal. Give it some time to bounce back, see what happens. Those first 3 to 4 days, it's okay to spend a little more time on the couch, especially if it's really bad. After that, you've got to test yourself, get yourself moving a little bit and see how you respond. And then if it's still lingering around a week out, I would get a call into somebody, whether it's your primary care, whether it's your friendly physical therapist, whether it's your chiropractor, whoever you trust with management of your low back, give them a ring and get in to talk to them. Because like I said earlier early management is essential for this. And if we can get someone in the clinic in the first couple of weeks of injury, then we have a much better chance at fully resolving the issue and resolving it relatively quickly. But if it's allowed to linger around for a month, 2 months, 3 months, then our hope to fully resolve it goes down, and then we start shifting our focus onto giving you a way to successfully deal with the pain and manage it in spite of it. But the pain would probably still be a part of your life in that case. Now, when we look at the acute low back pain, we would consider starting care with physical therapy, and I'm going to kind of bring principles in from all these other bullet points or sections that we have down here. So the times where you would want surgery for acute low back pain would be those cases where, again, you go back up and you say, things are getting progressively worse. Neurologic changes, all these bad things are happening. I've lost control of my bowel and bladder. That is where if you call a physician, they're going to get you on the first surgical table in the first room and get things addressed quickly, because things don't come back if they're allowed to linger at that level. So that's a really good reason to have back surgery. If you don't have all that going on and it's been lingering around for a little while, then considering physical therapy. And initially we can consider managing it with generally the idea of physical therapy is to be physical and move. So we want to get you moving. Sometimes it hurts too much to move, and we can use some other things to help you move with a little bit more comfort. Those things would be like hot packs, cold packs, ultrasound, electrical stimulation, traction, joint mobilizations where we actually get in and mobilize your spine, stretching, massage. At Alliance, one of the things we pride ourselves on is having a lot of different treatment options for people. So because we don't want to give up on people. We want to keep trying to find a way and fight with them to help them feel better. So we can come at it from a lot of different angles, both with the specialties that we have as practitioners, but also with some of the other treatment modalities that we can offer. So that is a good way to initially help you move better. But at the end of the day, the key is that you're moving, and we give you exercises to build on that and follow up with that. Then if we get you moving better, then we can help build strength to prevent that from happening in the future, which is to prevent the back pain from happening in the future, which is a real key. So there's kind of two phases to the rehabilitation process. There's the initial injury, and then rehabilitation from pain, and then there's the actual strengthening that we will focus on as we go further through it. So that gives you kind of an idea, and certainly as we're going through this management, we look to get help from the rest of the medical model. So if you have symptoms, neurologic symptoms that are really persisting, not getting worse, but they're really lingering around, sometimes maybe an epidural injection can be helpful to help calm those symptoms down and help you move forward a little bit more. And maybe, like I said earlier, a cortisone dose pack could be helpful to decrease that overall just sensitivity of the system. So we've got to definitely work closely with our counterparts in orthopedics and primary care and physiatry to help push the individual forward as fast as we can. If we're unsuccessful in that management, or if the management has lingered, or if the pain has lingered around for a while, then things can become chronic, which is frustrating, but it's certainly not the end of the world. And chronic pain does not mean the pain is always with you. It just means that you've got pain in your back frequently. and it is something that you know that if I do XYZ, I'm going to probably have some back pain. But if I do ABC first, then maybe I won't. So you kind of understand the principles behind what causes your pain, what makes it better, what makes it worse. And so just remembering with acute pain, imaging is important, especially if you check any of those boxes we discussed above. Imaging is definitely an important thing to help guide that initial treatment. Then when we get to chronic pain, the need of imaging, the benefit of imaging decreases, because especially at this point, we're focused on function, like I said earlier. Generally in physical therapy, we want to just see how you're moving, see what your symptoms are doing, and then intervene accordingly. So with chronic pain, that's even more of our focus. We want to understand what your symptoms are telling us. We kind of read the symptoms and go through a really extensive assessment for you. So when we're looking at why things become chronic, like why does the pain become chronic, there's some risk factors that the individual would have. One is obesity, the other one's smoking. That's a shocker. those two always end up being thrown on the list. Then we have high initial pain levels, history of depression, working in difficult positions or carrying heavy loads. So things, and I would take working in difficult positions as meaning a lot of different things as I review those studies, because it's you could think of like an electrician or a plumber that has to get in under a sink and is in a very awkward position, but you could also think of someone that's sitting all day. Those are also bad things for your back. So that's kind of an odd general term to say just working probably is an increased risk factor for low back pain. And you've got to do what you can to minimize the stress on your spine by spending the time that you're not working moving, and by spending the time that you are working being cognizant of some healthy positions for the spine. Then that's a kind of a good jumping off point to say, when we look at risk factors, there are modifiable risk factors and non-modifiable risk factors, meaning things we can change, things we can't change. High initial pain level, something we can't really change. You're going to have the pain that you have. However, a lot of these other ones are things we can change, things we can have an influence on. And with that, we can decrease your risk for causing chronic low back pain. So those are important things to keep in mind. I would be willing to, even though the studies that I reviewed didn't have these on here, I would be willing to throw in just generally like a lack of exercise as an increase for low back pain, but I'm biased because I'm a physical therapist. So historically poor management principles is another reason that back pain becomes chronic. When we look at low back pain, just the term low back pain is a little inaccurate in that it oversimplifies a complex issue that has a lot of different pieces to it. So if we take, and this is what had been done for years with studies of low back pain, they take, okay, this population of people has low back pain. Let's give them this intervention and see what happens. And we realized that it kind of worked for some, didn't work for others, and then it wasn't very applicable to our treatment, to our in-clinic treatment. And so we kind of realized that oversimplifying and calling this whole big group of people low back pain isn't really accurate. We need to start to pull individuals out and see what tendencies they have for response to treatment. So then we have to look at things like, okay, what type of low back pain are they having? Okay, do we need to look at the imaging specifically, like people with disc issues and do studies on them, people with stenosis and do studies on them? Or do we even take it into a different direction, instead of looking at the imaging, looking at people that tend to prefer being seated because of their back pain, and their back pain is better when they're seated, versus people that prefer to stand and they have better symptoms when they're walking and things. And those ideas are the ones that have really gotten some more traction as far as management goes, those ideas of symptom behavior and then modification based on that behavior, then looking at the actual imaging and basing treatments on that. Because I've had patients that have had disc issues, which commonly disc issues are they prefer to be standing and walking and extended. That's a better position for them. But I've had patients that have had disc issues that prefer to be flexed forward, and that's a better position for them. So if we only base it upon the imaging, then we're going to lose a little bit of what we can do as far as management goes. So we've got to look at our management principles, and the biggest thing is to break that out into different groups and understand that each individual that has back pain is going to be unique and have their own individual issues, and then build on that as much as we can and build studies around that, which we've done a better and better job of. And so at the end here, I talk about passive and active treatments for chronic low back pain. Just remembering that, yes, passive is nice. Like, passive is helpful to help you feel better in the moment, but it's not going to get the job done. At the end of the day, if you're just getting your back manipulated a bunch and like some heat and stim, it's going to feel better that day, but a day later it's going to come back and you're just going to keep having the same issue. So we've got to make sure that you have active interventions as part of this treatment. And active interventions, walking is super, super fantastic for people, but it's not everything that we should be doing. we've got to be strong. We've got to build strength. And that's something that I really harp on a lot, is that we need to keep working, even as we get older, working on strength. And working on strength training as we get older is arguably more important than any other time in our lives. So being afraid of not feeling like you need to go lift weights as you get older and things of that nature is really just doing a disservice to your body. You've got to be able to lift weights, load that, move things. You're probably not going to lift the same weights you did when you were 20, but it's going to do you a lot more good to lift that weight when you're 70. And then I would also say, as you get into that, make sure you're doing it safely. Make sure you're aware of your body mechanics, and hopefully you can consult with a professional on exactly how to do that and how to build that. So you've got to keep moving. That's the big thing. Surgical management is historically has poor outcomes. 50-50 is kind of the best you can hope for with certain procedures. The thing is that all procedures aren't created equally. So if you have a case where you have some nerve pain down the leg and it's getting a little bit worse, it's not getting better, then doing a procedure that's called a microdiscectomy, which is basically they go in and shave that jelly off the side of your disc, and that can help significantly with patients. And that is a procedure that I've seen that has had really good outcomes in cases where I wasn't getting anywhere. Then there's other surgeries like the spinal fusion surgeries, which have had historically worse outcomes. Now, that's not to say there's no reason for them, but you'd have to think, I would encourage you to think long and hard and make sure you've checked all the boxes of conservative management before getting a spinal fusion done. And by checking all the boxes, I mean, physical therapy, obviously, the injections, some medical management beyond that, like oral management with medication and things of that nature, before you really consider that fusion as being your best intervention. And hopefully, as the historically poor outcomes with surgery, I think, is a lot of based on patient selection, because surgery influences anatomy, right? So surgery, the only thing surgery takes into account is your anatomy. And if we go back up here, this stuff up here is all about your anatomy. What's wrong with your anatomy? What did the imaging show? And this isn't always what's causing the symptoms. It's just, like I said, you can have people that don't have back pain and have this anatomy. So the anatomy alone isn't what's causing your symptoms. So by going in and surgically repairing the anatomy, you're only repairing part of the issue. And so hopefully, as we approach back pain and all the different types in a more conservative way and treat it with physical therapy, with injections, with medical, with pharmacological management, whatever it may be, we can prevent a lot of people from getting to that point where surgery is considered for them. And the ones that do make it all the way through all those treatment techniques and still have some significant issues, they would be better candidates for back surgery, because we tried to fix everything else first and it didn't resolve the pain. So this is more likely than not an anatomical issue that needs to be addressed surgically. So that's a hope as we improve our awareness of medical management and patient selection with surgery, which a lot of the surgeons around here do a really good job of. So that is, for sure, if you've had back pain in the past and you've gone to a surgeon, you've probably been sent away just as often as you have, as people have been brought in to have surgery, because they know that their outcomes aren't great if they intervene in the wrong patient. So they want to make sure they're sent to PT and sent to different practitioners along that path. A lot here at Alliance, for sure, we get a lot of those because we have a pool in our Murraysville office, so that we end up getting a lot of patients that have been to spinal surgeons, and it was kind of their last ditch effort to say, okay, before we consider surgery, let's just make sure we've tried everything, and why don't you go see everyone at Alliance and try to get some aquatic therapy and see if we can build you up. And it's something that we can have some reasonably good success with. The last thing to just touch on here, because like I said, I kind of have a whole spiel that I can get into on the exercise principles, but whenever I think about physical therapy, it's about using our body to heal our body. So we're trying, all the talk these days about regenerative medicine, right? There's commercials on the radio and things like that. Well, physical therapy or just exercise is the original regenerative medicine. So what you do is you stress the body through exercise to break down the old pathological tissue, the tissue with issues, and rebuild stronger tissue. This has an effect on the tissue specifically, but also on the central nervous system, which is your brain, and how it's using that limb or that issue, because the brain is the real gateway to pain. So the brain decides when to send pain and when not to. And if you just don't use an area, the brain thinks, okay, there might be something wrong with this area. We better look at it a little bit more closely, and then you're at risk for more pain signals being sent to that area. So this is something that we've got to move to heal. And if you look at it from just a tissue perspective, whenever I have patients that have like muscle injuries, like muscle strains or tendon injuries, where you have some tearing and injury in the muscle, oftentimes the intervention is to load that muscle, which is always something that people had been avoiding up until the point they get to physical therapy. They think that they need to let it heal and let it recover, which is true initially for the first week or so. And then we've got to load it. And because, like I said, we've got to break down that old tissue to build new, healthier tissue. The body responds really well to slow graded stress. So the best way to think about that and visualize that for our body is considering the difference between a callus and a blister. If we look at a callus on our hand or on our shoes when you're running or what have you, it's something that you have some slow stress on that skin over time. And in response to that slow stress, the skin thickens and becomes harder and more resilient. Whereas a blister is when you get a lot of stress all at once, and it just tears, the skin tears, and you have that injury. This happens in all of our tissues across our body. So you could even think of it in bone tissue, like fractures are what happens when that bone gets stressed really fast and really fast and really significantly. The bone just gives way and fractures. However, if you stress that bone slowly over and over again every day, then we end up with stronger bones. And that is one of the management techniques for people that have osteoporosis. So this is how the body responds, and we just really harness that idea in physical therapy and in exercise to help improve the body's health. And something else to consider is that blood flow brings life. Like blood flow brings nutrients and oxygen to tissue. All the tissues, for the most part, in the body, except for the discs and the joints, the joint cartilage, they don't get a lot of blood flow. Only the outside border of the discs really get any blood flow. Otherwise, it's more of an avascular tissue. So how do they get nutrients? Joints and discs get nutrients through fluid intake and outtake. So I talked about the fluid earlier, going in and leaving, going in and leaving. When that fluid comes in, it brings nutrients. When it squeezes out of the discs, it takes those spent nutrients away, and then it creates a vacuum effect for more nutrients to come in. And how does that happen? That happens through movement. So we've got to move to get that fluid exchange in your cartilage, in your joints, and in your discs. Otherwise, the health of those declines significantly. So movement is really medicine in these cases, and it's going to help improve the health of all the tissues in the body. When we're hoping to improve health through movement, we want to make sure that we're moving in a healthy way and not a functional way, like a way that our body is designed to do. However, there's patients and people that work in positions, like I said earlier, that are challenging for the body. So when we're talking about low back pain, sometimes people will oversimplify it and say, well, just don't like twist a lot and don't bend over, like, and also don't like breathe in a certain way and don't walk more than like 150 feet. It just oftentimes things that are kind of unrealistic. And The thing is that our body does respond well to progressive loading, and there are some times where you don't want to do a certain movement with back issues, but more often than not, what you need to do is build into that movement slowly over time in a methodical and intelligent way to help to improve your tolerance to that movement. And you'll be surprised what you can do as you build slowly into movements to build your tolerance, because people can really do amazing things slowly building things over time. I mean, someone doesn't wake up one day and they're able to run 300 consecutive miles, but people do it. And people do it because they build things slowly over time. And so even someone that has back issues, if maybe their 300 consecutive miles is being able to make it around the block once without a numb foot, I mean, that's a big deal for people. So those are the goals that we take into account as we work with people in physical therapy, generally in medicine. That's kind of the principles we want to make sure it's patient focused, and we're not just working on what we want to see. We want to work on what you want to see. Okay, that's it. Hopefully it wasn't too boring. Any questions? Of course, I said I was going to keep the chat up and I didn't, but no questions, so we're good. Feel free to, any questions you can ask now. You can chat them into the box there. I have a little bit more time that I could stay and talk a little bit, or also I have my email there that will serve as a good option for people too.
I do have a question.
Yeah.
Is it possible for back pain to transfer pain to other areas of the body? For example, I've noticed that when my back is really out and it's just hurting so bad, I will get a really bad pain also in my thumb, and it seemed to be a correlation, but I don't are the nerves linked to other parts of the body?
Yeah, so that's interesting. Not directly, right? So your back. So if you think of your spine, starting at your neck and working your way down, you have little branches that branch off of your spine, and those are the nerves that come into your that go and innervate your whole system and go all around. The nerves that innervate your thumb come out of the base of your neck. So while no, that's not going to directly correlate with the low back, whatever you're doing that's causing your low back pain to be worse has a potential for putting extra stress somewhere else. So say your back pain is bad, so you sit funny, so then you tilt your neck a little bit, and then your thumb bothers you. There's probably some biomechanical correlation there, but not a direct neurologic correlation.
Gotcha.
Yeah.
Thanks.
Mm-hmm. So I think the next time we're going to talk about arthritis or osteoporosis. I forget which one, but one of those two. And I'm happy to build this and do more and more with it. So one of the things that I would like to just throw out there is to, if people thought that it wasn't terrible listening to me for an hour, then you could ask me to talk about other things too. Well, things that I could really actually talk about with some knowledge. There's things that I don't know much about, but yeah, anything from the perspective of orthopedic care and physical therapy and things of that nature, feel free to send me a message about it, or I'm sure you could send Kat a message and let us know, and we can kind of build something around that.
Yeah.
All right. Well,
Okay.
Thank you, everyone.
Thank you for joining us, Colin. That was great. That was very informative.
Good.
Thank you.